very hard for me.
Alexandro, you still look good, huh? Keep it up, keep it up.
I try to. I really try to.
11, 5, 4, 3, 2, 1.
Good afternoon, everybody, and welcome to our Tuesday AIG International COVID Updates, which comes every afternoon Tuesday from AIG. This afternoon, this week, we have great pleasure in having one of the most important and probably most distinguished worker in this area in the field of GI endoscopy, Professor Alexandro Repici from Milan. Professor Alexandro Repici is in the center of the whole issue that's going on, COVID in northern part of Italy. In fact, not only is his hospital, the Humanities, converted into COVID hospital, but he was the one who gave us all the guidelines initially on how, as endoscopists, we should be seeing and treating these patients. In fact, his first paper in GI endoscopy has become viral, and most of the societies that subsequently put up guidelines were actually quoting from this paper. Ali is not only an outstanding endoscopist, an outstanding researcher, but a great friend. Even in the non-COVID times, I remember the type of publications, the warm relationship we had. And then when I asked him whether he could do this for the South Asian countries, he gladly agreed. And we're extremely glad that Professor Alexandro Repici is here with us to talk about his experience in northern Italy, which has been the main epicenter of COVID. And co-moderating this session with me, we have also some very eminent Southeast Asian endoscopists. Professor K.L. Go from University of Malaya. He is, of course, the leader of endoscopy. He's been the president of APW and, of course, so many other titles. And I'm glad he's here with us. Professor Farooq
Thank you, Nagi. It's a pleasure.
Professor Farooq is the president of Bangladesh Gastroenterology.
Professor Alexandros Repici's lecture, which we all look forward very much to hearing. And I want to congratulate you for taking the initiative and effort in getting all of us together and organizing this very, very laudable effort. Of course, I wish to thank Professor Repici. As you've mentioned, he's a leader in GI endoscopy to share with us his experiences with endoscopy during this terrible COVID times. Together with me, I introduce my colleague, Professor S.H. Ho from GI endoscopy in my unit, and others. As you can see, we are sitting far away from each other to practice social distancing, although we have taken out our masks. And we look forward very much to this afternoon session and look forward to questions and answers as well and comments later on. Thank you.
Thank you. So, Ali, it's all yours now. You can start the talk. Yeah. Your sound is not, can you, sound? Ali, your sound is not on, just a second. Ali, I think you have muted your sound. Can you just check whether you have muted your sound? Yeah. Okay.
So now.
Yeah, now it's coming.
Can you hear me?
Yeah, we can hear you. We can hear you.
Okay. So first, good afternoon, everybody. And it's a great pleasure to join the Asian community of gastroenterologists and endoscopists. And thanks, Nagi, and thanks to your institute for organizing such a wonderful webinar on-air meeting. And I must say that I feel really humbled by the presence of so many eminent colleagues from so many different countries. And I hope that sometime soon we can see each other in person. So also thanks, Nagi, for the introduction. So I feel my connection with that part of the world extremely strong, and I think that in the past, Nagi has been a nice ambassador of that part of the world in our hospital. As you can see, he came to our meeting on a regular basis. He was working with us all the time. He provided a lot of teaching to our trainee fellows, and physicians. So we are so glad that we can be considered a part of your network of physicians. So let me start with the presentation. I think it's important that everybody knows that the name of the virus is SARS-CoV-2 and COVID, coronavirus disease. COVID is the name of disease. So we know that the virus can get in our body through different access, so through the mouth, the eyes, the nose. And we know that there is a specific connection which is required to virus to be incorporated in our body, which is the ACE2 receptor. There is a strong evidence that this receptor, the ACE2 receptor, is present, is well represented through the entire GI tract. And also there have been a couple of reports initially from China physicians saying that the RNA of the virus can be detected in the stool. Also, we know that gastrointestinal symptoms are present in patients affected by COVID-19. We have just completed our own investigation on about 400 patients with pneumonia who have been admitted in Milano with also some GI symptoms, and we try to build a Kaplan-Meier curve looking to the overall survival and also to the number of patients requiring intubation. And we were able to demonstrate that when we compare patients with pneumonia GI symptoms to patients with pneumonia alone, there is no difference in the clinical course of these patients. So this means that these symptoms, GI symptoms, they are accessory symptoms. They do not complicate or they do not improve the course of the disease. One important point is where you can find the virus. Of course, we know you can find the droplets, saliva, feces, and also there is a recent letter in JAMA reporting that there is a number of patients with the positive either sputum and feces just after patients have been considered negative for the virus because of the conversion of the pharyngeal swab. I think somebody has to mute the mic, probably.
Yeah.
Probably. Okay, so, and also there is a recent letter in Nature Gastroenterology trying to investigate whether or not there may be risk of fecal oral transmission. And in this letter, so guys, I think
Yeah, I think
probably
yeah, maybe
somebody has to mute.
Sorry, KL, Farouk and Tantanai, can you mute the mics there because we're getting some echo here. So can you all mute the mics?
Yeah, we are muted already. We are muted already.
Yeah, thank you. All can mute the mics except Ali. Because,
Okay. I think now it's much better. Sorry, there was too much echo. So in this letter, the author saying the precise mechanism of interaction between the virus and the receptors into the gastrointestinal tract is not completely understood, even though we know that the ACE2 receptors are highly expressed in the gastrointestinal tract, especially in the small bowel. So there are so many articles that you can get in literature. This one about the hepatitis A vaccine has been published yesterday on Experimental and Clinical Transplantation Journal. And also I want to mention for the youngest fellows being part of this webinar that there is a very nice article on gastroenterology. It's in the section Impress under free download. And the title is Why Does This Virus Invade the Gastrointestinal Epithelium? So also I want to suggest that if you want to get a very up-to-date list of papers on GI and COVID, you can go to this website. This is the website of the Italian Society of Gastroenterology. You can take a note of that. It's free of charge. You can download all the articles published in this field. We have included more than 250 articles. We have a young team of fellows, of GI fellows, that look every day to what is going to be published in press in any journal, and they put freely available in this library, which is just open to everybody. So, of course, altogether with many papers in the field of GI, there have been also a lot of papers in the field of endoscopy. And as Nagy said, we started writing the first paper on what the department of endoscopy should know the first few days of March. And I will tell you the story how this paper came out. So we were invested by this storm. So we were really unprepared. And the last days of February, we got the feeling that something really extraordinary was coming. So we had the meeting with the board of the hospital, and they said, okay, we cannot take care of all departments. So every department has to develop its own policy on protecting patients and physician and nurse and hospital care personnel. So we developed our own plan and we presented it to the board. Once it was approved, I received a call in the middle of the night by Mike Wallace, who is the editor-in-chief of Gastrointestinal Endoscopy. He's a very visionary guy, he's fantastic, tremendous person. He pushed everybody for innovation and for being very up to date. They said, hey, Ale, I'm sure you are working on this issue, and I'm sure that America is just a couple of weeks behind of Italy. Why not prepare a paper that we can publish soon to give guidance to the other colleagues around the world? So we basically prepared the paper overnight. So he called me, there was almost midnight, and the day after, around 9 o'clock in the morning, we had the paper written. So, and we shared it with the leadership of American Society of Gastrointestinal Endoscopy, and I feel very indebted with all these leaders, including the president, John Bargo, and the other guys, the guys in charge of publication committee, because they accepted the paper straightforward. So we submitted the paper at 9 o'clock, and the paper in few hours was already accepted and was put in press the day after. So this is the story of why we were first. We were working on our own protocols, and we received this call, and we shared the protocol with the other colleagues. So what is the situation yesterday? This is the picture I prepared yesterday before leaving the hospital, in our hospital. So we are about, which can be a nice picture of every hospital or every big hospital in Milano. So we are about 900 beds hospital. So as per today, we have still 180 patients COVID positive, majority of them admitted with pneumonia. So 20% of them, they are requiring some form of ventilation, which may be Venturi mask, CPAP, whatever, and we have still 34 patients in ICU. So things are going better in emergency department. We're still admitting around 15 patients COVID positive every day. In the middle of March, we were admitting also, we are admitting up to 35 to 40 patients every day. And what is important to know that we have discharged more than 150 patients. When we discharge the patients who have been admitted with the COVID pneumonia, they all go to quarantine. So they don't go home. This is why the regional health system authorities have created some spots for facilities for providing quarantine. So they took hotels, other facilities with bedrooms. So patients are referred to these places, and they are served with the food, with everything they require, but they don't go straight forward to home. And finally, a very sad issue in Italy, in Milano especially, was the mortality, because we had in-hospital mortality of about 11%. But what is terrible, that 1 in 5 patients being admitted to ICU because they have a severe dyspnea, they died because of the pneumonia. And when we look to the data about the infection in our hospital, and we were quite good because we were able to contain the infection rate below 2.5%. If you look to the data from China and from other countries, there have been reports saying that 8 to 10% of hospital care personnel got infected. So I think this is good news for our hospital. This is a map to show that we are just here in the middle of the epicenter part. Probably this part of the world is having the worst ratio between number of people, population, and number of infected people, and number of deaths. So we are just in the middle of the storm. And only in the area of Milano, not the entire country, there is an estimation that probably about 1 million people, 1 million human beings have been infected with the virus. So numbers are probably 10 times higher than the official report saying, because the official report saying they have 2 problems. First, they are based on the number of patients who are going to be tested. And the second one, they are not updated, because once you tested and you are considered positive, these data, they are moved from the regional health authorities to the national health authorities, and normally it takes about 3 to 4 days, so they are not really updated. So what are the topics that we will be shortly talking today? So the practice, the PPE, and what has been the impact and the protection of physicians and nurses. So let's start from the practice. From first week of March, we have been ordered by the regional health authority to try to cancel all elective procedures. So we canceled all elective procedures, all screening, colonoscopy, and we also canceled all patients referred for follow-up after endoscopic resection or surgery, and also we canceled all the pre-surgery investigation because all elective surgery has been shut down as well. So what we did, we understood we were creating substantial issues, we were raising concern among patients, so we developed a specific communication plan for our patients on a hospital basis, and we set up an telephone and email helpline. So we try to give the feeling to the patients that they were not left behind, they were not abandoned by the hospital or by the endoscopy department or by the GI department, and we try to answer to their questions, to their points as much as possible. And at least for the first couple of weeks, this helpline worked extremely well. We were in contact 24 hours per day, just trying to answer to all of them questions. So if you look to the map, we have we did a nice survey, nationwide survey. We investigated 120 hospitals in Italy with more than 4,000 healthcare personnel. So, and that's dramatic. What we reported, the paper is going to be published on Digestive Disease and Liver Journal. And so 60% of our hospital experienced the significant challenges with shortage of masks and also shortage of our protective devices. And also the other point that we got, that 1/4 of all GI units, they were converted to COVID wards, to COVID beds. So and when you look to the map of Italy, this is a paper which has been accepted in gastroenterology, is already available, and looking what's happened to our country in terms of endoscopy volume, you see that most of the regions, they reduced the endoscopy volume by 75%. So in average of 18.5 endoscopy procedures as compared to the months of the previous year are still performed in Italy. So what kind of procedures? We discussed it a lot internally, also with the Regional Society of Endoscopy, the National Society of Endoscopy, and so we adopted the strategy to perform only emergency and urgent procedures. And this is the volume in our own hospital. You see, we were doing still significant number of patients in the first 2 weeks of March. By March to have, everything has been completely shut down. What we're doing now is just about 10 to 15 patients per day, and while we were doing in the same period of the past year about 85 to 90 patients per day. So we're still doing ERCP for jaundice, pancreatic cancer. We are still doing EOS for malignancies. We are a referral center for ESD. We do about 40 to 50 patients every year with the early gastric cancer. So we're still doing ESD for early gastric cancer because we don't want to convert these patients to surgery. We want to treat them as long as they have still a superficial neoplasia. We're still doing a couple of polyps with very ugly appearance, with significant risk of having invasive histology, and also we're treating we are performing endoscopy patients with strongly symptoms suggestive of severe disease, like we are draining infected collection, we are taking care of patients with dysphagia and bloody diarrhea. So this is important because we were very interested in understand what was the risk of getting the infection either for the patients and for the healthcare personnel working in endoscopy workplace. So this paper will be in open access in GAT since tomorrow. So what we did, we organized a follow-up for 1,000 patients, with about 1,000 patients who underwent endoscopy in my unit between the second part of March and second part of February and first part of March. So we called them, we repeatedly called them until we got 2 weeks follow-up. So the interval to make sure that they were not or they were infected with the virus. So among 1,000 patients undergoing endoscopy procedure in Milano in the midst of the crisis with the coronavirus, only 8 patients developed respiratory symptoms. 6 of them were tested, but only 1 resulted positive, and this lady got positive just 16 days after she was treated in my unit for colonoscopy. So we are not really sure whether or not this lady got the infection in the endoscopy workplace. So these data are really reassuring. So it means that you are working well, you're following the policies of protective measures. The risk for the patients to be admitted in endoscopy is really minimal. So how to manage the patients? This is important. So you can get the nice results only if you organize your work in advance. So we call everybody the day before, and we have a questionnaire with a number of different issues that we discuss with the patients, including the area they are coming from, even though all around here is red zone, and we investigate whether or not there is any family member with respiratory symptoms, or if the patient has been in close contact with somebody very suspicious for COVID. When they get into the hospital, they again receive a triage, we again evaluate body temperature, and we change the policy. Nobody is admitted in the endoscopy space, so no relatives. And of course, we organize a team of nurses for those patients who need a specific care, who are not independent themselves, they need to be assisted. So we reinforced the team of people taking care of these special patients. If we change the layout of the recovery, now there is a significant distance between, so they are not crowded any longer. There is a specific distance between two patients, and all patients, once they are admitted in the endoscopy workplace, they have to wear masks and gloves. So this table, this attempt of risk stratification has been built at the end of February, so it's not updated any longer, but at least in Italy, but probably can be used in regions or specific areas of the world where the incidence of COVID is much lower than in Italy. So if you are in most of your regions, the incidence of infection has been much lower, and probably the response from yourself guys has been better. So you still can probably stratify the patients according to their risk of having been in contact with the virus. And of course, this is important because according to this risk stratification, you can differentiate the use of PPE. Of course, you know there are different kinds of PPEs that are to be used, including double gloves, goggles, masks, and water-resistant gown. But the main problem that we have been discussing for about, I would say, 4 to 6 weeks is the main question is why we as endoscopists need to be protected so much as compared with other kind of hospital personnel. So the main question was between myself and my team, and also among the entire, with the board of the hospital, and also on a larger basis with the other physicians and with the National Society of Endoscopies, is endoscopy aerosol generating procedures? So I think in general, the answer should be yes, because this has been in the past. You know that especially with the upper GI endoscopy, we can generate droplets through coughing or retching or sneezing or whatever. But there is a nice paper that has been published, I would say, middle of 2019 in GI endoscopy, looking into the role of facial shield in protecting against exposure of biologic materials. And this was the first study to confirm that when you use facial shield, you can detect biologic material, infected material on the facial shield, but in the same time, the facial shield is very protective. So, and also if you look to this systematic review, which is the only systematic review that have been published about aerosol generating procedures and risk of transmission of viral infection, acute respiratory infection, you look here, the authors listed the number of aerosol generating procedures considered for the systematic review, but upper GI endoscopy is not listed as one of the potential risky procedures. So there is a little bit of confusion and also of different angles and perspective of looking to the risk of upper GI endoscopy. And this is an impact on the facial masks because, you know, there are different facial masks that they provide a different level of protection. So ideally, I would like to have this mask for everybody. But we know this only conceptually because indeed these are not available in many countries. They are not available in many hospitals. And this is also these very nice review articles looking to all these aspects on the value of N95 respirators versus surgical masks that's been published recently. And when you look at the recommendation from the different health institutions, including the American CDC, WHO, different professional societies, there is a disalignment. They are saying different things in the same time. It's difficult to follow all of them. And there has been a recent joint gastroenterology society message from AGA, American College of Gastroenterology, American Society of Gastrointestinal Endoscopy, just recommending N95 for everybody and for every procedures. But this is not possible in our situation, and this is unrealistic because of the shortage of the N95. And this is another paper that we have submitted yesterday to gastroenterology. We looked to the number of physicians and nurses in the endoscopy workplace who got infected during their activity. So we investigated on about 1,000 endoscopy healthcare personnel. Only 212 have been tested because it's also very difficult to get the test here in Italy. We have limited resources for testing, and only physicians and nurses who were symptomatic, they had access to the test. And if you look, the amount of people who resulted positive to the test is very minimal, 28 physicians and nurses, and only 8 4 physicians and 2 nurses in the red zone of Italy around Milano. They were requiring a hospital admission. They are all doing now extremely well. Nobody has required ICU admission. And also, we prepared, in this paper, we did a subgroup analysis. So it was a sort of a randomization, retrospective randomization, because number of hospitals, majority of hospitals were wearing N95 for all procedures. And there was another group of hospitals, including our hospital, which were wearing a standard mask for all procedures except N95 for patients who were non-COVID. So when we did the subgroup analysis, the amount of people who got infected in the 2 groups, they were very similar. So we could not find any statistical significant difference in number of healthcare personnel working in endoscopy according to the different use of the mask. And this is very, very reassuring to us. And also, doesn't mean that you are not protected if you're not wearing the N95. So this is myself yesterday performing the last ERCP of the day. And as you can see here, we're still wearing double gloves, skinny gloves, surgical gloves, plus another pair of gloves. We have a gown water-resistant gown. On the top of surgical mask, we wear another surgical mask. I don't know if I have here. I had before for the presentation. Yes, let me show. So you see, what we wear also, we have, let me show this first mask. Plus second mask with the transparent facial shield, plus we wear also the glasses and the hairnet. So I think that wearing all these protective measures and being very stringent with the adoption, with physicians, nurses, everybody, is still a very strong protective role. So these are pictures taken from special guys working in my team. I think I have to pay tribute to all they are doing. Most of these guys have been relocated to emergency department, to COVID positive beds, whatever. So, and we are all wearing the same PPE, and we have been very lucky in protecting ourselves. So the take-home message for you guys is there is not just the mask is protecting yourself. So you cannot wear just N95 and everything will go well. You will be fully protected. It's the combination of all these measures, the dressing protocol, very strict hand hygiene, the social distancing, the space organization, the team organization. All these single points are relevant to the impact of increasing or decreasing the risk of the transmission of the virus in the endoscopy workplace. Of course, there is plenty now of articles and videos, especially there is one beautiful video in Video GIE. The editor is Gotumukala Rayu. It's a very visionary person. I love so much what he's doing in this special time. So you have access to a lot of resources to understand and to do some training activities with your own team on how to do that. Of course, there is a different approach for those patients who are known COVID. So we have done a couple of COVID positives. So I was telling before we are going live that I've been in call this weekend, and on Saturday night I did a very, very tough upper GI bleeding in a COVID patients. So how we treat these patients? So for that patients, N95, so the other mask is mandatory, and we have a different, we'll say, dressing code, reinforced dressing code. We do endoscopy in a dedicated area. So we created in our endoscopy an area which is specifically dedicated to these patients, and also the recovery room has been reorganized. There is a big barrier. The two patients, COVID and non-COVID, they cannot stay in contact. And also we do this is a okay, thank you. So there is also negative pressure room. So we are doing these procedures also in negative pressure room. When we did the survey in Italy, only 25% of endoscopy, they were equipped with a negative pressure room. So my suggestion is, if you do not have a negative pressure room in your endoscopy place, please move to surgical theaters. They are very well equipped, they have a negative pressure room. And the other point is, since at the end of procedure, you have to provide a very careful disinfection of all the surfaces, stretcher, bedsides, whatever. So please do not overstuff your endoscopy place, your new layout with endoscopy instrument, because more you bring in the room of COVID positive, more you have to clean them. So please be very minimal in equipment and trying to get only what is absolutely mandatory for providing the procedure to the patients. And finally, also restrict the access to the COVID area only to the nurses and physicians in charge of procedure. So this is a very important slide. We reorganize our team in two teams. So one is working in endoscopy for 1 week, and the other team is working in smart working from remote. And they are taking care of patients, sending email, reorganizing the schedule. And this will allow us to minimize the risk of exposure for the entire team in the same time, and also to have a sort of backup coverage just in case a couple of guys in the team get infected. And also it's important that you change your normal behavior. We love together all together, and to drink espresso, and to comment and to talk and to stay around the same station. This is impossible. We cannot do any longer. Everybody has his own station, computer, phone. We are forbidden to share everything. We take care of our own place. We disinfect our own place. And we try to use as much as possible, very properly, the surgical mask and the N95, because we have very limited resources. There are no differences in terms of scope disinfection. There is a robust evidence literature showing a virus are normally destroyed following the strict rules of manual disinfection and cleaning with the machines. So what we have done, we reinforced the message to our team in charge of scope disinfection, try to be very careful, strictly follow the European Society of Gastrointestinal Endoscopy guidelines for scope cleaning and disinfection, and I think this is enough. So of course, these are my last slides, just to invite all of you to get connected to this big event. There will be on-air live endoscopy course. Of course, Hyderabad will be one of the main pillars of this event, and in a time with so many events cancelled, the ESG days cancelled, DDW cancelled, we don't know if there will be UEGW. The decision about UEGW will be taken, I think, this week. So I think that having on-air event, travel-free, so 12 centers from 5 different continents will broadcast for for about 8 to 9 hours for the entire day. This will be free, open access. All our young physicians, all our fellows, all our people can follow the event and get some information on new techniques, new technology, innovation endoscopy, and so glad that Nagi accepted to be one of the protagonists of this event. So this event has been designed all together, invented all together with Thomas Roche, and I want to really thank Thomas for what he's doing for supporting this event. And you know, I was organizing in Milano a live endoscopy course since about 10 years. And last year I decided to shut down the meeting because I said we were good, we have done for 10 years. This is time to shut down the event, and I think I was very lucky because normally we do the meeting in June and this would have been impossible to be organized. So this is the faculty of our course. You see there is a bunch of experts, including some Indian American guys like Pratik, Sham, and the other guys, and we will be involved very seriously. We will try to do our best. You see, there will be cases of any kind of endoscopic procedures. And this is my last slide. I think that everything will be fine very soon. Thank you so much.
Thank you, Ali. Thank you very much for that fantastic talk. I think you covered a very wide area, and in fact, you not only we have the original data from GI endoscopy, but a lot of new data that you showed us. I'm sure actually we're getting a lot of questions, but we have limited time. We'll start by asking KL Go and his team from Malaysia regarding their questions for this. KL?
Thank you, Nage. Thank you. Alessandro, excellent talk. Coming from somebody who has seen many, many cases. We are seeing a lot of cases as well, but not as many as you all see in Milan and in Italy. Maybe I ask Dr. Ho to enlighten us how many cases we are treating now in the hospital, and then if there's any other questions you want to ask.
Hi, Alessandro. This is Xiaohui Ho here. Thank you for your excellent talk. As Professor Go mentioned, our University of Milan Medical Center is also one of the COVID hospital. And so far, we like in your centers, we cancel all the elective cases and we perform cases only for emergency and also urgent cases, so to say. Our urgent cases here include those with cases that needed the evaluation for cancer and cancer treatments. Of course, emergency cases refer to bleeding and cholangitis cases. So far in the hospital, we perform endoscopy under full PPE cover, like what you mentioned. And COVID positive patient, we also perform it under negative pressures room. And so far, we do not have cross infections among healthcare providers so far. Okay.
Thank you.
Congratulations.
The thing is that the urgent cases that come in, they're all not tested for COVID because there's no time to test them for COVID. Some private hospitals, they are doing some elective cases, so then they require that all these patients have COVID testing. But you know, our fundamental rule is that if elective cases, we shouldn't be doing them in the first place. Yeah.
Thank you, Kale.
I totally agree on that. What we do if a patient is coming in emergency because of a life-threatening situation, we consider this patient as a high risk, like positive. So we do endoscopy fully protected. While for elective procedures without symptoms and without significant contact with the COVID positive patients, we do not have any chance to give them the test for the rapid test. So we just do triage and we body temperature and nothing else. So I want to update about the rapid test on blood. You know, there is a blood test with a drop of blood. You can get tested. So right now, FDA has approved 75 rapid blood tests, 75. none of them have been tested in a prospective clinical study, zero. And 80% of them, they come from China. They've been tested in China, internally in China, but we don't know the results. So as a matter of fact, we tried to make tests with 6 different of them here in Italy, and the results are totally crazy because we have COVID patients with pneumonia admitted in the hospital. They resulted totally negative to the rapid blood test, either during the hospital admission and even at the end of the hospital admission when we suspected they should have been positive for antibodies like IgG. So I think we can more rely on the rapid blood next to those patients who can have access to endoscopy.
So unreliable test, in fact, is more confusing.
Yeah, you're right. Totally right.
Thank
Great.
you. Thank you. Farooq from Bangladesh. Any
Yes.
What do you do in Bangladesh?
So that is.
Thank you, sir, for allowing me to join with you. In Bangladesh, our hospital is a national institute for GI diseases. But recently, with increasing problem of COVID in our country, as there is shortage of hospital beds and hospital number, government has decided to make our hospital a dedicated hospital for COVID. That's why right now we are preparing to convert our hospital from GI institute to a COVID hospital. And that's why our endoscopy service is now temporarily, we are not doing any endoscopy because we have to discharge all patients from our hospital, and we are now preparing to admit only COVID patient here. So when COVID patient will be admitted, and we have gone through all the guidelines as from British Gastroenterology, Chinese guideline, and also recommendations from AIG. And we have decided to follow the guidelines. If we do need to do endoscopy in any patient with COVID, in that case, definitely we will follow these guidelines. And hopefully we will do this endoscopy only in cases who need it as emergency procedure. Otherwise, routine endoscopy procedure will not do during this time of COVID. But I want to ask you one question. If somebody, some patient opted by himself that I want to do endoscopy, and if he is not a COVID patient, so this is an elective procedure. Do you advise to do endoscopy in such situation if anybody opted for this procedure willingly by himself in a COVID hospital?
Ali, you want to take that up? So elective endoscopy in a patient who wants endoscopy done, can we still do it in this time?
We are approved to do these patients only if they are really symptomatic. So we do not accept patients saying, please scope myself because I don't feel good or whatever. We have a triage of symptoms, and only if the physician believes that this is a real needed endoscopy, we will book the procedure. Otherwise, they will postpone probably to about 8 weeks from now.
Oh yeah, maybe some patient may need this procedure as a follow-up endoscopy, or there might be some compelling indication. Although if it is not emergency, in that case.
Yeah, for follow-up, you're right, but it depends on the kind of follow-up. It is very important follow-up. I think you're right. You should admit in the hospital, but if it's 5 years colonoscopy after tiny polyp resection, of course you can postpone to September. It doesn't matter too much.
Thank you. So we have Tantanai from Myanmar, Professor Tantanai.
Thank you for inviting me to participate in this webinar, and thank you, Dr. Rebisi, for your excellent talk. So actually, our country has COVID confirmed cases are much less than other country, only 120 cases up to now. But I'm sure the cases are uprising, particularly asymptomatic carrier who has contact with the COVID positive patient. so that these asymptomatic carrier patients are dangerous to the public as well and to our endoscopy unit. And now we scheduling the cases only for emergency cases, as Dr. Ho said. But the problem for ERCP cases like acute cholangitis, after doing procedure, how do we sterilize the equipment like a scope processor, electrosurgical machines, X-ray machines, fluoroscopy machines, and C-arm?
Yeah, okay, good point. So first, so I'm glad to talk with somebody named, and I've never been in your country. I know it's beautiful, so thank you. And when at the end of the ERCP, for the scope, we do twice the manual disinfection rather than once. We do twice. We are very careful, especially with the tip of the scope. And afterward, the machine disinfection process is exactly the same. So between one ERCP and the other one, rather than a few minutes interval, we have now 30 minutes. So this 30 minutes is because people have to get in the floral room and they do very careful disinfection. But of course, before we started the RCP, we use plastic protection, transparent plastic bags and protection to cover as much as we can. So most of these plastic transparent material will avoid any contact of the C-arm, of the floral machine, of the beds, whatever. So we sort of dressing code also of the instrument, okay? So using this dressing code, we remove all these protection at the end of the RCP. It's very easy to clean. In about 20 to 30 minutes, everything is perfect.
Thank you.
In fact, we are getting many questions from all over the world. I don't think we have time for this, but we have one interesting question and comment from Chun Woon from I think China, and his was that this study which you quoted between surgical mask versus N35 having equal findings, I think is extremely important study. Are you publishing it or is it published? Because this will become very important.
So we submitted them. Yeah. And we hope they can get acceptance somewhere, hopefully in a very nice journal. We submitted it 2 days ago, so we are waiting the answer.
Okay. So as I said, there are many questions, but we don't have time. But we like to end this, Ali, with a very special gesture to all the heroes in Italy, the doctors who fought COVID, and also all these individuals who are still fighting COVID there. We like to end this with a special national anthem, or Italian national anthem. Thank you very much, Ali. Thank you, KL.
Thank you so much on behalf of my country.
Thank you, and KL and Tanta and I. So we end this very interesting seminar with lot of information that we got from somebody who's worked in the original areas where all this was there and produced so many guidelines. Thank you very much, Ali, and thank you for all the listeners. Next Tuesday we come out with another international COVID symposium from AIG, and this time it's going to be Guido van Ham, who is a very famous international virologist, who is going to talk to us about the future vaccines and so on. Thank you very much, Ali. Thank you very much.
Thank you, sir.
Thank you. you so much.
Thank you.
Thank you.
Thank you, sir.